Good morning. I think we're ready to resume with Miss Harvey-Wood.
That's correct, Lord.
Right. Good morning, Miss Harvey-Wood.
Morning.
Now, you have given evidence previously in the inquiry, I think on the 18th of September of last year.
That's correct, yes.
So you'll be broadly familiar about the way we proceed. I think to begin with, you're prepared to affirm.
That's correct, yes.
Sitting where you are, could you repeat these words after me? I solemnly, sincerely, and truly
I solemnly, sincerely, and truly
declare and affirm
declare and affirm
that I will tell the truth,
that I will tell the truth,
the whole truth,
the whole truth,
and nothing but the
and
truth.
nothing but the truth.
Thank you, Miss Harvey-Wood. Now, we're scheduling you for the next hour and a half, broadly speaking. But if at any time you want to take a break, just give me an indication and we'll take a break. Now, Mr. Connor.
Thank you, Lord. Good morning, and thank you for returning.
Good morning.
You produced for the inquiry what's been described as a consequential witness statement. Can I just ask you the formal question? Are you content to adopt that as part of your evidence?
Yes, I am.
Thank you. Now, I think I've been advised that you've got in front of you a copy of your own witness statement on which you've made a few notes of one kind or another. And I certainly had no difficulty with that, and I suspect his lordship will have no difficulty with that
Thank you.
either. So feel free to consult it as we go. It's possible that you may feel that some of the questions that you'll be asked are returning to questions you have been asked before.
Okay.
But that's, I'm afraid, a consequence of the way matters have developed over the period of time. So your witness statement, consequential witness statement, obviously sets out a fairly long association with York Hill. Is that correct?
Yes, it is.
About something over 30 years there?
Yes, I was at York Hill for 32 years. And then when York Hill laboratory moved to the QH 2012, I was there for 2012 to 2023. So most of my career was at York Hill Hospital.
So you were still dealing with York Hill prior to the fact that, for instance, the Schehallien unit moved in
Yes.
to the new hospital.
Should I take from that, and I'm sorry if I'm being slow about that, you're physically at York Hill Hospital until 2012.
That's correct.
2012, the labs moved, and you moved with the lab to what I think now is the Queen Elizabeth campus. Is that right?
That's correct, yes.
Right. And you remained in post between 2012 and 2023. Is that right?
Yes, at the QH site in the new laboratory building.
Right.
In the 3 years between 2012 and 2015, till the hospital moved to the campus site, in that 3 years, the laboratory was no longer on site at York Hill, but we went back daily to York Hill Hospital to attend ward rounds and give advice. We also had a hot lab at York Hill, which did urgent samples. There was a biomedical scientist there as well doing urgent samples on request of clinicians to prevent delays of samples being transferred across, especially through the Clyde Tunnel, from York Hill to the campus at QH. So there was a hot lab for 3 years as well. We were given mobile phones, which enabled us to be in contact with York Hill staff at any point in time. because not being on site, we felt, was a bit of a change in the service provision, because if you're on site in a laboratory, you can just walk across and go into the ward. If you're off site, you know, the geographical distance isn't far. But if you're in your car and you're travelling, it can take a bit of a journey. So we always went at one point in the day, the microbiology staff who were transferred from York Hill would go back to York Hill at different points in the day. Sometimes in the morning, we would go there first thing and then travel on the QH site.
Right.
That was for the 3 years.
So despite the move in 2012, you're continuing to provide support to, among other services, the pediatric hemato-oncology service,
Yes.
which is still located in the York Hill Hospital
That's
site
correct.
until 2015.
Yes.
Thank you.
So
As I say,
they moved the lab before they moved the hospital, because the lab building was ready in 2012.
right. Thank you.
And am I right in thinking, in fact, that your focus was entirely on paediatrics?
Yes, it was. I haven't done any microbiology in the adult speciality. My training was specifically for paediatrics, which I retrained even after the move to the new site at QH.
We find a lot of that set out very helpfully in your consequential witness statement. I might just call it a witness statement, just make it less of a mouthful. Can I just ask you about one thing that you mentioned, just to make sure that we're understanding what you are saying? In paragraph 1.12, which electronically is on page 20 of your witness statement, page 3 of the hard copy, you talk about something called a spring bloom. Now, you say that it can lead to an increased risk of infections. Now, first of all, what's a spring bloom?
It was an increase in the bloodstream infections that we would see in the early months of the spring as the weather got warmer. And it was just like an annotation, it was a kind of phrase we used in microbiology. And there is literature, which I've referenced one, to say that it does happen, you know, in the environment when the weather becomes a bit warmer, the temperature changes, that the bacteria start to grow. So sometimes we would expect small peaks in the spring months, but they were never of any concern, and I don't have any recollection of having outbreaks of environmental organisms or anything during these kind of what we called spring blooms. It was one of my colleagues that used to use the term, and so it was just a kind of, it's difficult to explain, just a terminology we would use in microbiology, there's a wee bit of an increase in blood cultures, but it was never of any clinical concern.
Well, that's what I just wanted to check with you, because in paragraph 112, you say that it's something that can lead to increased risk of infection, but in 113, you said it wasn't investigated as it didn't have a detrimental effect on patients at York Hill. Is that what
That's
you're
correct, yes.
telling? Now, let me move on a little bit and use your time at York Hill to advantage. I think you've been asked to consider the suggestion that there were considerably higher numbers of cases of environmental concern in York Hill compared to the new hospital. And you've expressed a view on that, I think in paragraph 2.1 of your witness statement, where you say you don't accept that. Is that your position?
Yes, that's my position.
And that's based on presumably some considerable contact with what I might describe as what was going on in York Hill over the years. Is that correct?
Yes.
Can I ask you to look at another document, because things are always moving on. As soon as we think we pin them down, they move again. Can I ask you to look at bundle 44, volume 5 at page 50? This is a more recent production than some of the other comments. And I'm not going to ask you to discuss the epidemiology in any great detail. But you see the graph and you see there's a red line and there's a pink wider line, if I can call it that, in a very non-technical way. Now, if that was to be understood as indicating that there was a trend which was perhaps slightly down, perhaps somewhere around 2015, and then rose to a peak somewhere around 2018 before dropping off after that point. Would you recognize that pattern as something that matched or did not match your experience?
I think that would match our theory, and also was referring back to the graphs I presented at my last oral evidence. You can see that there is an increase with the smooth linear line over 2000 and starting 2017, end of 2016 up until 2018-19. Of interest for me actually is the negative or 0 points in the black dots, which are the incidence rates. You can see that prior to the move, there was quite a few low or zeros, and then after the move, in the first year post-move, again, a larger number of points at 0. And then for me, the most interesting thing here is as well, is that after all the interventions and mitigations, and in 2020, you can see the zeros appearing again, and more appearing, so they're closer together. In 2022, after the refurbishment of the Schehallien unit and the patients being back into the unit, the trend is downward in York Hill. There isn't that increase that you see with the GAM fit on the smooth line during the period of York Hill analysis and data.
Okay,
Sorry, could I just, it's just my noting, Ms. Harvey-Wood, you said what was interesting was after the mitigation and interventions. Now, what are you taking as the period of after the interventions and mitigations?
I would say you're looking at sort of where you see the line falling down, but when it falls down and then kind of becomes more straight. So I would say 2020, if you look at the graph at 2020, it's when the lines cross as well. If you see, that's about the point where the blue and the pink line are sort of cross in 2020. Do you see that, where they sort of join together again? I would say around about then. And also this is at the same time as when you see the negative, where you've got 0 incidence rates.
Yes. Now, having established the point that we're talking about, you drew attention to the number of 0 points, which I take to be represented by the dots coinciding with the x-axis of the graph.
That's correct, yes.
Right. Thank you.
Millard. I'm going to, you mentioned the materials you produced previously. I'm going to put these back up again just in a little while. But if you can bear with me for the moment while I ask you 1 or 2 other things just in passing. I'm not going to ask you about everything that's in your witness statement, purely for practical reasons. Can we look at 225 of your witness statement, page 25 of the electronic version, 8 of the hard copy, just at the top of the page there. Now, you seem to be taking a view about the use of normal to describe a particular bug, which I'll, as usual, not pronounce correctly, Acinetobacter. You see what you're saying there?
Yes,
And what's your point, just so we understand it?
Well, what I was doing was responding to the statement in the HAD report, page 96, where they said that, however, this pattern was the norm at York Hill, suggesting this may be the usual presentations population, which I thought the comment really wasn't appropriate because they're comparing it with sporadic cases at QEH. Acinetobacter should never be normal. So I don't know why they use the word norm, rather the abbreviation as well, rather than normal. They're obviously, from their data, they've shown there was cases of Acinetobacter at York Hill, but it would never be considered as a normal infection.
Can I just ask you about that? If there was an infection of that kind in York Hill, was it dealt with?
There was occasions when we had an increase in an infection, and if it was thought to be of clinical concern and the clinicians had raised it as well as infection control, then we would investigate it. And I have put an example in my statement of a Pseudomonas outbreak in the paediatric ITU. So that there was instances where we would investigate it, and as I said in my statement, a very close relationship with the infection control nurse at York Hill, who used to come to the lab every day, and we would discuss any concerns. So it's probably difficult to prove this with documentation historically, but if we were aware of a problem, inverted commas, or a concern, then it would have been raised with infection control at the time. And in context of this, the National Infection Control Manual wasn't available for part of the time at York Hill. I think it was 2012, I think it was introduced.
That's our understanding.
So if you're looking back before 2012, the kind of statutory infection control guidance wasn't in place.
I don't know whether you can help us with this or not, but one thing you might take from the statement in the HAD report was that this population, i.e. this cohort of paediatric hemato-oncology patients, had a kind of norm of this particular bug. Do you know whether that was found in the new hospital?
Acinetobacter cases.
Yeah.
We did see it, yes, but I would say of all the sort of environmental organisms, it probably wasn't the predominant one, but it was seen, and they'll have the information in the HAD table as well. But yeah, we did see it, but it wasn't one of our concerning organisms, and as you'll see in my statement, it was more of a concern in the paediatric ITU actually, rather than the Schehallien patient group.
Thank you. I've been asked to ask you some questions about paragraph 230 of your witness statement and what follows from that. In paragraph 230, you explain that you were in touch with Dr. Bagradi because you wanted to bring to her attention what you describe as the first case of colonization with Dendrotrophomonas multifilia, isolated from a sample which was not part of, in your, what you say here, not part of the norm. And you were told, not interested, don't look for that. The way you've expressed that, were you expecting a different response from Dr. Bagradi?
Yes, I was expecting some note of interest because we were looking at the microbiology for the new unit, if you call it that, the refurbished unit. We were very interested in what would happen when they opened the new unit, when the patients were moved back in. We were concerned, would colonization happen again? Was the environment safe? So we were, if anything at all, from our microbiology results, was isolated that we thought infection control should be aware of, then we were emailing them and looking even more closely at the monthly blood culture statistics as well to look at, was there any increase in infections post move back to the refurbished unit.
But you were told not to look for it.
Yes, we were.
Was that what you expected to be told?
No, I would expect that they would want to know about Cenotrophomonas multifida, because it's one of the kind of key organisms, and I think I said that before. It's one of our key organisms that we use. Remember, like a trigger point, it's one of the organisms that when you see it, it kind of says, oh, it's like an alarm bell, oh, this shouldn't be here, sort of thing. So any environmental organism of concern, like Cenotrophomonas, is something we would want to bring to the attention of infection control. And also I informed my line manager at the time as well, who was involved with the email too.
If you ask not to look for it, does that impact on the reporting of this organism?
Well, that's exactly correct, because when you examine a microbiology specimen, you're looking for the bacteria in the sample that are infectious or infections, rather than you have normal bacteria in any clinical sample, but you also have the bacteria that cause infections. And we were screening feces samples from the hematology oncology patients to look for colonization with potential environmental or organisms that could cause infection. And this wasn't a new specimen type. We did this processing of screening, I think it's a better way. We screened certain samples of hematology oncology patients at York Hill as well, to look for colonization, to have an alert, an awareness of anything that might be concerning. So we used to do oral samples, stool samples. Each patient had a screen to monitor their potential infections. So the feces sample was part of that. We weren't looking for fecal pathogens. It was a separate code in the laboratory. So we weren't looking for pathogens that cause gastroenteritis. We were looking for organisms in the feces that would be a potential source of infection.
And can I say, I mean, you can't speculate beyond what you were told, but were you told why you were not to look for it?
No.
Now, you go on in paragraph 2.31 to quote part of the HAD report, and then you offer a comment on Stenotrophomonas multifida in paragraph 2.32. Just so we're clear, what's the point you're making in 232?
Well, 232 is just sort of falls on what I've just said. It's recognised as an important pathogen, and it can have a high mortality rate if it's found in the bloodstream and a bacteremia. So it requires close liaison with infection control. So this, is why I gave the example of the screening sample with a Stenotrophomonas, because it kind of referred back to a comment made in the HAD report that said that it really causes infection in immunocompromised patients.
You made various comments on the statistics and the comments on the statistics that were put to you for the purpose of this statement, and you accept that there were environmental organisms found in York Hill. But the foot of the page we're looking at the moment in your statement, you say York Hill environmental BSI infections did not have the same consequences or concerns at the time regarding patient morbidity or safety. You're putting quite a lot into one sentence there. What's the message you're trying to get over?
I think the message is that any hospital, if you look back at one of the other reports by Mr. Mukherjee, he compared different hospitals, paediatric hospitals, like Cardiff and Leeds and Great Ormond Street. They also had environmental infections in bloodstream. So all hospitals do have environmental infections. But the difference here in the QH was the diversity and the complexity of the infections. We did see infections from time to time in the environment at York Hill, but clinically, they didn't have the same concern. And I think, to refer back, that's okay, to Professor Gibson's witness statement, she also had the same impression, if that's the word to use. She also, as the lead of the Haematology Oncology unit, was not concerned that the infections were as serious, if that's the word to use, or in the numbers in close in time. So what we were seeing, what we're seeing at QH was a lot of infections at the same time with different organisms, whereas at York Hill it's more sporadic. We would see infection from time to time, but they weren't clustered into a shorter period of time and lots of them, if you know what I mean. The timelines were very different.
Okay, thank you. Now, earlier you drew His Lordship's attention to the materials that we looked at briefly. Now, I say briefly on your previous appearance because we did look at them, but we didn't look at all of them and we didn't take a great deal of time on them. So I'd just like to touch on them again as we have you here. That's bundle 19. Page 143. Now, we're going to look for a moment at some charts. But what we probably didn't do on the last occasion was note specifically that the document that this is part of, which you were part of preparing with Dr. Peters, first of all, who was it presented to?
This was presented to the Haematology Oncology unit, would have that information.
Yeah, and that's what, the clinicians?
Yes.
And just taking it generally, first of all, do you remember what reaction you got when you went through that material or the clinicians in this presentation?
They.
Sorry, just so that I'm keeping up. When you say this presentation was made to the hemato-oncology unit, is that the pediatric?
Yes, sorry, pediatrics. So, yes.
So the Schehalion unit?
Yes,
I beg your pardon. Mr. Connell?
So I'm just trying to take from you very generally, this is obvious, as we will see in a moment, it's a presentation with lots of graphs and so on and so forth. It's topped with a narrative and it's tailed with a series of conclusions. What were you getting? Shock, horror, agreement? Can you remember?
I would say agreement. I think they weren't surprised when the data was put into this format. I think it was what everyone was seeing. So I think it confirmed everybody's concerns that there was problems with infections and that we were being told by management that there was no infection concerns. And the CLAPSI group also produced graphs and data, and that also was very similar to the presentation here, or report. And in the actual PowerPoint presentation, I think there's a graph from the CLAPSI work as well. So they also, the CLAPSI team, which I was part of the CLAPSI team as well, their data and this data here were supporting each other. They were showing the same thing.
Just for completeness, because we probably didn't take it last time, particularly because we weren't focusing on this. I see, although this is produced by Dr. Peters and yourself, you also have another note there saying pharmacy data provided by Isabel Gurley, pharmacist. Now, does that cover things like antibiotics?
Yes, that was for the daily dose, the DDD. So to look at the different antibiotics in the graphs and the usage of the different antibiotics, we needed to access pharmacy information and their databases to look at the amount of antibiotic was used in the Schehallien unit for several different antibiotics over the time period of this report.
Thank you. Can we just,
I mean, just to repeat back that answer. So that means in October of 2018, there was data held by the pharmacy, which was specific in relation to the particular antibiotics being administered in the Schehallien unit.
They'll have data on all antibiotics, all drugs administered. I mean, obviously, antibiotic is one group of drugs. There'll be all the chemotherapy drugs, additional drugs that, pain, whatever, pain relief. So the pharmacy departments, there's within Schehallien, they have their own pharmacists who are trained in hematology oncology specifically. Isabel Gourley was one of the lead pharmacists for the hospital. So she would have got the information or the data on the antibiotic usage from the database from the Children's Hospital paediatric pharmacists. So pharmacists are trained in paediatrics as well as adults, a bit like microbiology. They're specialised in paediatric pharmacy and also in hematology oncology pharmacy. They're very specialised in that area too.
Yeah. I think the point His Lordship is trying to ask you is, was it possible at the time to extract information which focused on antibiotic use in the Schehallien unit?
Yes, yes.
And is that what you,
Yes, indeed.
as one of the participants in this, arranged to be done?
Yes.
Thank you. I'm not going to ask you about all of this because time wouldn't allow. Can we just, what we'll do is we'll just move through it and I'll pause on one or two of the graphs. So we just go on to the next page, please. Now that simply shows overall numbers of blood cultures, in case there's any question about that. 145. Numbers of patients with blood cultures, 146. That's increasing rates of positivity. That may show some things, but we'll probably see it more clearly in some of the later graphs. 147. What's being shown there?
So, for some reason, the green bar chart on the graph, I wonder what's happened to it. Oh, sorry, the green's the line. Sorry, I can see it now. Sorry, the green's the line. So I thought it was another. It's like another graph we had before. Sorry. So it's just showing just the number of patients at blood culture taken and the number of patients with positive blood cultures. So it's just showing that there was a downward trend in the number of positive blood cultures that patients had in the period of 2015 to 16, but the number of blood cultures taken remained the same.
Thank you. At 148, I want to come back to the polymicrobial question with you a little later on. 149. That's a much more complicated graph because that contains details of a whole range of individual organisms. Is that correct? What we have there is a graph which has a list of organisms down the right-hand side of the graph, which are represented by colours on the graph. Is that correct? And again, we see totals, but we also see a breakdown in this case of the...
It is breaking down the different types of microorganisms into groups.
Thank you. Then 150. That ratios we're looking at there. Again, there are quite a few graphs which show similar things.
Similar things, yeah. That's just presented as a linear graph as opposed to bar charts, yes.
Right, thank you. 151, yeah, it's just a note. 152, that's gram positive, so we've moved away from gram negatives for the moment. And again, a list of the individual organisms appearing, or abbreviations for them appearing down the right-hand side. 153, that's just a note again. 154, let's just pause here because we're talking about gram negatives, not exclusively, but quite a lot in this inquiry. Now, just very briefly, what is this showing about what's happening to numbers?
Well, it's showing two things. It's showing the increase in total number of the gram-negative microorganisms. It's showing that in 2015 to 16, there was no environmental organisms. HI is Haemophilus influenzae. That's
Sorry, could you just give me that again? It's showing that in
2015 to 16, the gram-negative organism that was isolated was not an environmental, because if you look at the key at the side, you can see the different colours, and ENT is green, and ENT, ENV is purple.
So ENT will be enteric,
Yes,
and ENT oblique environmental is an organism which can have an enteric source or an
yes, maybe like
environmental.
Enterobacter cloacae, for example. And then the kind of turquoisey blue line is ENV, is environmental. So I think to look at it, you need to look at these two colours together. That's the environmental and the environmental enteric. So that is the sort of turquoisey blue colour and the purple. So you can see post-move that the amount of gram negatives in that category increases in time to April 18 to June 18, where we've already mentioned that there was a peak in April 2018. So you have two things in that last bar chart. You have the highest number, and you also have within that the largest amount of the blue and the purple colour, which indicates that you have more of the environmental and environmental enteric organisms. If you look back then to just after the move, you can see that there is no blue or purple. And also in October 15 to December 15, January 16 to March 16, again, there is no blue or purple. We first see that colour in the chart in April 16 to June 16. And that is when I remember saying that I began to see the organisms appearing in the blood cultures. And to me, that was when things first started to change. And it's shown there in that graph.
Sorry, again, my fault for not just hearing that. When did you say that you saw a change?
Yeah, so in the chart here, if you look at April 16 to June 16, this column, thank you, is the first column post-move that is showing environmental organisms in the blue, and in the purple, environmental and enteric organisms. And the small amount of green is the enteric only group.
Sorry, Mr. Conway.
Thank you. Well, I think we have your explanation of that graph. Can we go to 155? Now, what's different about this one? Is it this is just environmental?
Yes. So the other previous graph included different types of gram-negative. So it was titled gram-negative organisms. So what Christine did was we teased out from that just the environmentals, and that's the three groups of organisms that I discussed in that previous graph, that the ones we were concerned about, the ones we wanted to see in more detail. So we took the other data out, so it was more obvious what was happening.
Also, there were gram positives here, is that right? We see the green.
Yes, there was some green, that's right, yes. Our environmental, and all our organisms included gram positives, as you'll see later in the presentation. But yes, we kept the gram positive environmentals in. So the previous graph, if you want to go back and look at the title again, just for clarification, was gram negative organisms, okay? So we then looked at environmental organisms, and from the legend at the side, you can see that we have environmental gram positives as well as environmental gram negatives. So it's a slightly different presentation, including some gram positive environmental. But what you can see from that is there wasn't as many environmental gram positive organisms as there were gram negative. And of quite interest in the graph, if you look back at York Hill, we didn't have any environmental gram positives. And the chart shows that the numbers, the total numbers, the height of the bar charts is much lower than post-move. And quite striking for me, if you look at that graph, is the gap where there's no organisms, which again refers back to what you saw in the HAD report. For me, it's always interesting to look at when there's nothing, when there's no organisms, when there's no infections, and refer that to when there is. What's happened, what's the change, why is it gone from no organisms to organisms being isolated, and why is it gone from a lot of organisms and a concern of environmental organisms, and then you see that they have gone away again. So it's a bit of a cause and effect there. So for me, the three different time periods post-move, you can see there's nothing on the graph. So there wasn't any environmental organisms.
So that's when the hospital is, as it were, brand new.
Yes, yes. The little red arrow in all the graphs is just an annotation to remind people when the move took place. So it's just a visual representation of that's when the hospital moved in 2015. And that's why it's June, because it moved 2015 in June.
That's migration of patients rather than any contractual handover date, is it?
Yeah, it was the actual patients move, yes. The actual move of the Schiehallion, because the patients didn't all move in the one day.
No.
York Hill moved from the site at York Hill to the QH site, and the patients went in wards or groups or specialities. Then the clinicians would go with them. So they moved in groups of specialities into the ward that they were given in the new hospital. So the move was kind of, and the Schiehallion was one of the last wards to move.
Thank you. Let's just finish this. 156. Well, let's not delay on that one. 157. Not sure what that's intended. What's that intended to show us? 157.
This is cases of VRE, which is vancomycin-resistant enterococci. This is a gram-positive enteric organism. The concern with that is it's called vancomycin-resistant because it's resistant to vancomycin. and it's an organism that is quite easily transmitted from feces. So it's found in the gut, colonizing. And the concern is that vancomycin is one of the antibiotics that's used to treat gram-positive infections in the Schehallien oncology cohort of patients. So it was just looking at the spikes of cases of VRE along with the blood cultures. I think it was, Christy described, I think it was just looking at other environmental factors and other concerns, as well as the environmental blood cultures. So it was just referring to the fact that for some reason, the number of VRE cases seem to kind of mirror slightly the percentage positive blood cultures.
Sorry, positive blood.
Yeah, so the red line is the percentage of positive blood cultures, and the blue line is the cases of this resistant organism found in the feces, which can cause outbreaks. And I think Professor Gibson referred to that as well as rotavirus. But I'm not sure why. What we're saying is we saw this phenomena, but we're not sure why the blood cultures would peak at the same time as the cases of VRE. It was just an incidental finding.
Well, I just want to ask you about one or two more things in the time we have available. One of the issues that you covered in part of your presentation was focused on antibiotics. Is that right?
Yes.
Prescribing and so on. Can we just go on? We'll turn each page, but I want to pause when we get to antibiotics. 158. Leave that. 159. Yeah. This is daily dosage figures. Is that right?
Mm-hmm. This is the information that we had requested from pharmacy. This was information that is regularly provided from the antibiotic usage within the Schehallien unit.
We go to 160 and 161. Tell me what this graph was designed to show.
It's quite a detailed graph. So you've got your environmental organisms as a bar chart. So superimposed on that is the antibiotics. So you're looking at 3 antibiotics: ciprofloxacin, meropenem, and tazocin, which are highlighted in different colours as a linear presentation.
What do you take from that? Do you take any particular point from it?
Well, it just shows that, the lines go up and down, up, down. There is, if you want to call it a small peak of meropenem use in the beginning of 2015. Then again in 2018. This may have been due to organisms that were resistant to tazocin. You can see the tazocin line is not going up, so it's sort of staying static up and down. But then as the meropenem goes down in 2015, Q4, the tazocin goes back up again. That's the usage. So these 2 antibiotics are used for different reasons. So tazocin is a first-line antibiotic. So when the patients first become unwell, they're given tazocin plus or minus gentamicin. Once they get the results back from the laboratory, if the organism isolated is resistant to tazocin, then the antibiotic is switched to meropenem. So you can see that the lines cross over each other as the antibiotics are switched or used, depending on what organism is isolated. So the antibiotic use is tailored very much to the laboratory report with the antibiotic sensitivities, and they're guided by that on the choice of antibiotic. The next 3 lines are dashed lines, and they're showing when the organisms were resistant. So the dash of the yellow line and the dash blue line are organisms isolated from blood cultures that were resistant to the antibiotic. So if the antibiotic's resistant, then it's switched. The organism is resistant to the antibiotic, then it is switched.
Sorry, it's my fault entirely. I think I failed to follow the point you make on dotted lines. Could you give me that again?
Yeah, the dotted line is organisms that are resistant to the antibiotic. So the dotted lines are actually organisms, not antibiotic. So the thick line is the antibiotic usage.
So the solid line
Yes.
is yeah.
The dash line for Meropenem and Tazelson is organisms
Which are
resistant to that
resistant.
antibiotic. Yes. And the blue bars are the total number of organisms.
Right, and I get the resistance from the letter R.
Yes, that's correct,
right.
yes. So when you get resistance, if you refer that back to the solid line, you'll see that the antibiotic usage changes with the resistant organisms being isolated. So if you look at, for example, to give you an example, if you look at 2016-2 and to 2017-1, there is a slight increase in the dotted Tazelson line. So that means we were isolating organisms resistant to Tazelson. So if you go up to the same point, 2016 Q4, you can see that the solid Tazelson line fell because we weren't using it to treat infections because we had resistant organisms.
Right, so the policy on antibiotic administration follows on the results showing resistance to particular antibiotics.
Yes.
Thank you.
But when this was displayed to the Schehallien unit clinicians, do you remember, did you get any concerns, disagreements?
No, I think it was what they were seeing. The concern was the Tazelson resistance in that it's the first line antibiotic. So you can see there's a sort of two peaks there, 2016.
These are organisms
Yes.
which are resistant to what would normally be the first line antibiotic.
Yes, but with that, the caveat with that is that they use gentamicin as well. So we use what we call double cover. And that's why we do that, because it gives you a broader cover against bacteria that are in the blood culture, but we don't know yet what the sensitivity pattern of that organism is. So to give cover, quite often they start 2 antibiotics, we call double cover, and then when you have the results back, you tailor it to the results from the lab. So you may change one, you may stop one, or you may continue. And that's where microbiology clinical with the Schehallien unit was very important.
And gentamycin's not on this graph?
No, it's not on this graph, no.
Okay. Well, I'm content to move on from that to 162. Just in general, why are you particularly looking at Meropenem?
I think this is because there was a question, and I think it's been addressed previously, about Meropenem usage driving resistance or driving resistant bacteria. And so there has been audits performed on Meropenem usage. It can mean 2 things. It can mean that the increased usage was due to resistant organisms being isolated that we couldn't treat with Tazelson. Then the question is, do by doing that and using another antibiotic, do we select out more organisms that are resistant to meropenem? It's cyclical, that's what happens, then you switch antibiotics. But there's been quite a lot of work around this issue. And from our microbiology perspective, we didn't see a driver for selecting out resistant organisms. And the big example here was obviously Stenotrophomonas, which is resistant to meropenem.
So what that graph shows is not numbers of meropenem doses. It shows a rate of meropenem use per gram-negative
Yes, exactly.
blood culture.
The number, yes. So it's related to the number of blood cultures and the organisms that we isolated from the blood cultures, what antibiotic we would use to treat. And this is just teasing out from the previous graph the meropenem usage against the number of bacteria, the gram-negative bacteria.
And the comment there is that the rate is stable since the third quarter of 2016.
Yes.
Sorry, just give me that again.
The rate, I'm reading from the top of the page, my lord, that the rate of meropenem use per gram-negative blood culture is stable since the third quarter of 2016.
Right. Can I ask you just, you said that quite a lot of work has been done on this. Is that work that you were involved in, or?
No, there was an audit performed by one of the consultant microbiologists on meropenem usage.
Sorry, there was an audit?
Yeah, performed by Dr. Alison Balfour, microbiology consultant. And we also looked in more detail at the use of meropenem in the DDDs. And then there was the questionnaire response, which I responded to, and Christine Peters did, that I received.
That was the recent?
Yes, the recent, yes. It's part of the public inquiry. Mm-hmm. This has already been addressed, I think, yes.
But
the hypothesis that meropenem use was driving the results had been raised in 2018. Is that right? The hypothesis? I'm just looking at your graph and assuming...
Yes, yeah, that's probably correct. That's why we would have looked at it, yes.
Yeah, right.
In the timeline of things, that would have been around the time we had the peak of organisms. I think it would have been looked at then as part of what we call the increased incidence or water outbreak. They'd have looked at different parameters of concern regarding the increase in gram-negatives.
And is that chart a reflection of Dr. Alison Balfour's work or your and Dr. Peters' work?
This is Dr. Peters' work in conjunction with the pharmacy, this particular graph.
So the pharmacy information that's used to determine how much meropenem had been used and so on and so forth, that comes from the pharmacist that you mentioned earlier?
Yes.
Thank you.
We requested that information from pharmacy, or Dr. Christine Peters requested that information from pharmacy.
Well, I'll need to move on from your presentation shortly. Just going to 163. Well, I suspect we can probably leave that one. 164. I can see it's similar. 165. And another bar chart. And then do we get to the end at 166? And what you now do is you basically summarize what you take from the various charts that have been set out above under various headings: epidemiology, antibiotic use, and resistant patterns. So is this material that would go to the clinicians, these summaries?
Yes.
And what was the reaction to these summaries?
As I've said before, they we're not surprised at the information. I think it was helpful for the clinicians because they also, from a clinical perspective, in seeing the patients and the infections in the patients around about 2018, when obviously this data was collected and analysed, that it supported their concerns, and I think they thought it was helpful in that we were showing in graphical form what they were seeing in the ward and the patients. Because remember, the clinicians aren't seeing all the results coming out the labs. They're not collating the data. They're just seeing individual patients and looking after that patient and that patient's infection. But if you put it all together in a graphical presentation, it shows that there was a pattern and that there was an instance of gram negatives. And I think they found it helpful.
Thank you. Well, we can leave that document. Thank you very much. I'm just going to ask you one or two more, and then we'll have a short gap while I check if anyone else has questions. You've made various comments. We have obviously all this material, whether you deal with it orally or not, and you've pointed out that there were lots of interventions started in basically 2018 onwards, and you've set out a lot of these in your witness statement, and also your view on whether you were seeing exogenous or endogenous infections, and your view was that there was an increase in exogenous. I've been asked to ask you about a different part of your witness statement, paragraph 411, which is on an electronic page 34, hard copy page 17. I think the question you're discussing in these sections is the use by the HAD report of material collected about municipal drinking water. Now, do you think, is that a useful exercise in your view in this context?
I wasn't sure, as I said in my comment there, of the relevance of it, because the actual purpose of this publication was to look at resistance genes in the water. However,
just to clarify, the purpose of this publication, are you referring to the Kahn paper?
Yes, sorry, are you referring to that? Sorry, am I?
No, I think yes, the Kahn paper that's referred to in turn by HAD.
Yes, the HAD report referred to this publication with regard to environmental contamination or environment or in water systems. And as we've heard through the evidence this week, water is not sterile. There is organisms in the water. But they were looking at tap water from Glasgow residencies. What we have is patients in a hospital where there is a tank, a big storage tank of water. It's slightly different. My opinion is that it's different water. It's hospital water. It's not tap water. And there's plumbing systems in hospitals. There is stagnant water in hospitals. The children in hospital, which we're concerned about and we're discussing here, are immunocompromised. They're more vulnerable to infection. Their immune system has been compromised or immunosuppressed. In the public water supply, you're giving water to the general public. So I wasn't convinced that the relevance of this publication referred to an outbreak because they used it in the context of discussing an outbreak.
Have you read the Kahn paper?
Yes, I have.
Right. The reference in the report by Dr. Agrawal and his colleagues, if I recollect correctly, draws attention to the Kahn paper, which I think was maybe published in 2014. But the reference simply says the identified microorganisms were the most commonly found. Now, what was the Kahn paper's purpose?
Well, that's, they said in it, the aim of the study was to look for resistant genes. What they were looking for was bacteria in the public
Yes.
water supply that had resistant genes. The relevance of that to a hospital and hospital infections was what I was challenging, because I wasn't sure why that reference was used in that context.
When you use the expression resistant genes, is that resistant to antibiotics?
Correct, yes.
Right.
Resistant genes, antibiotic resistant genes.
Right.
Bacteria carry on their, how to put it? They carry resistant genes. They can,
I think it's probably enough for my purposes to understand
yes,
that it's about
rather go into the
resistance
terminology,
as
yes.
opposed to
Yeah.
how their resistance
On plasmids and all that sort of stuff,
arises.
yeah.
Right.
I just wasn't sure. I mean, the HAD report's a very big report, but when I was reading it, it was just something that it kind of stood out. And I thought, oh, I'll read this reference. It looks very interesting. Environmental bacteria. They've used a statement, environmental bacteria occur widely in the general environment. And I went, oh, that looks interesting. So then I went and looked at the reference and read it. And then I made my comments on it because I couldn't quite connect the relevance of this publication to what they were referring to it within the section of an outbreak.
Mr. Cullen?
I think I possibly only have two more points to take from you, and I hope to be able to take them both fairly briefly. When we were going through your chart, I'm just calling them your chart. I know you're a co-author. We kind of skipped past one about mixed blood cultures. You take the trouble to set out your comments in narrative form, I think in paragraph 5.3, which is at page 35 of your witness statement, and you highlight the fact that you had 11 mixed blood cultures in the first year after the move to 36 in 2017 and 40 in 2017-18. Now you say this was of concern. Why was it of concern?
Because a bloodstream infection or a bacteremia is normally caused by one organism that colonizes the line or gets into and enters the bloodstream. This was infections with more than one. You could call it polymicrobial, which is what the heading of the question that you gave me, polymicrobial. So that is a concern because there is more than one organism. It's a mixed infection, more difficult to treat because you need to use quite a few antibiotics to treat it because there's more than one organism. This usually means that the line has to be removed because treatment of a mixed or polymicrobial infection is much more difficult. And also it alerts you to the fact that there's something not quite right. Why are patients getting, an increase? So you're getting, as you pointed out, you're getting an increase in the number of mixed blood cultures, from 11 up to 40. And that's a lot of blood cultures in a year that have more than one organism. It's also a lot of work in the laboratory processing this sample, looking at all the organisms that you've isolated. So it does bring it to your attention. And it does, for me, suggest there's some source, there's some problem, because most blood cultures are of a single organism.
Thank you. You were asked a not untypical question in the questionnaire, basically, have you anything to add, any views on the impact of the environment? And you've set out a lot of detailed views that I'm not going to get you to repeat orally, and they appear in section 8 of your answers. I just want to ask you one question, it is just because it jumps out as slightly different from everything else, and that right on page 40 of your witness statement, under current ongoing issues, C, you say staff have had to use hand gel as the water was not safe due to high levels of chlorine dioxide. Now, am I right in saying you just picked that up in the newspaper?
No, two things. I have referenced it as a newspaper, but I do have colleagues that I know this has happened to. They were told not to use the water and to use hand gel because I think it was due to the increase of the chlorine dioxide levels was unsafe. And for a certain period of time, they were asked not to use the water. And this is quite recently, in the last year.
My Lord, I have no further questions for this witness,
But you would wish the opportunity to check with the
just
room.
in case.
Yes. As you may recollect, Ms. Harvey-Wood, what we do is check with the other legal representatives, rather, if there's any further questions. So could I invite you to return to the witness room, and it should be no more than 10 minutes.
Could I ask Lord Brodie, is it okay for me to make a comment about something that I've not been asked about?
Well, I think, in fact, you may or may not have been invited to do so, but it is all right for you to make
Is it
a comment.
appropriate to do it now, or do you want me to do it at the end?
You may wish to do it now so that the legal representatives have the opportunity to respond.
Okay.
I should say, if I feel you're perhaps going too far away from your central area, I might intervene, but if you have a comment, please make it.
Yes, it was regarding the oral evidence yesterday by Dr. Dumright. She was discussing graph on page 51, which is from bundle 44, volume 5, graph 51.
Yeah, that you were shown page 50
Yes.
by me this morning, which was the environmental.
Yes.
This is the non-environmental.
Yes. These graphs were part of my bundle of documents to read to prepare for today. But the reason I'd like to raise an issue is that it was stated that the non-environmental organisms, their infection rates may be due to the lab not working and the laboratory contamination of samples. I would dispute that fact. And I feel that this comment was made without any reference to any information or any details of laboratory practices or the working of our laboratory, or had Dr. Dumright been in our laboratory to see how we process samples, our SOPs, our guidelines. So I just feel that that comment was a bit unfair.
You listened to Dr. Drumright yesterday, as did I and everyone else in the room. Now, my recollection is that at that stage in her evidence, she was discussing what the expression that was used were counterfactuals. In other words,
Correct.
possible. And my recollection is that she made it quite clear that she was discussing, my recollection may be wrong, but this is just my recollection, that she was discussing counterfactuals, other possibilities. And I think there was a list of about maybe six of these. So as I understood her, she wasn't saying that this occurred as a matter of fact. She was putting it forward as a possible explanation for what was the events that were seen, the rates of infection. And again, this is my recollection, she excluded lab infections as unlikely. That's my recollection of her evidence. But I'll bear in mind what you've said, and it's part of your evidence, and as part of reviewing the evidence, I will be going back to the transcripts anyway. So I think I understand the point, but in fairness to Dr. Drumright, my recollection is that she was just putting this forward as a possibility, not so much as a possibility of what might actually have happened, but as an analytical method of considering how particular events may have arisen. But thank you for making that
Thank
point.
you. Thank you, Lord Bodie, for considering that. Thank you.
Right. So, as I say, we'll should be able to get back to you in 10 minutes. Right.
Fred? Apologies, my lord. Practical issues involving changeover, just intervening a little there. But I can announce that there are no further questions for the
Right,
witness.
we'll invite Ms. Harvey-Wood to come in, and if there's any housekeeping to be addressed, we can do that afterwards. Ms. Harvey-Wood, there are no further questions, which means that you're free to go. But before you do, can I thank you for your attendance today, which is the second time you've given evidence to the inquiry, but also the preparation that went into not only your previous evidence, but your evidence today, and in particular, responding to the new material. But thank you very much. You're free to go.
Thank you, Lord Foley.
Right, with apologies for breaking into the obviously important discussion. I mean, are there any, what I would propose is that we take an early coffee break and sit again at 11:15, but is there anything we need to decide before then?
Not as far as we're aware.
Right, okay, well, we'll have coffee and see each other again at 1:15, where I understand Mr. McIntosh will take over.
We stand.
Now, Mr. McIntosh, are we able to resume with Dr. Agrawal?
Yes, Lord.
Good morning, Dr. Agrawal. Now, as you understand, you're about to be asked questions by Mr. McIntosh. But first of all, I understand you're prepared to affirm.
Yes, Your Lordship.
Now, sitting where you are, could I ask you to repeat these words after me? I solemnly, sincerely, and truly
I solemnly, sincerely, and truly
declare and affirm
declare and affirm
that I will tell the truth,
that I will tell the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Thank you, Dr. Agrawal. The timetabling for today will be that we will plan to sit until 1 o'clock, take an hour for lunch, resume at 2, and proceed through the afternoon. We usually try and finish by 4, but your evidence is important, and it may be that we go a little beyond 4. However, and I wish to make this very clear, if at any stage you want to take a break,
Yes.
for whatever reason, just give me an indication and we will take a break. So please feel that,
Thank you.
as it were, you're in control of the situation. Now, you speak, to my ear at least, very clearly. Could I ask you, nevertheless, maybe just to speak a little louder, maybe a
okay.
little, with a little bit more projection than you would in normal conversation, because the room has to hear you. The microphones are intended to help, but from the perspective of someone wearing hearing aids, I'm very conscious of
Okay.
the need to be clear. Now, Mr. McIntosh.
Thank you, my lord. Dr. Agrawal, if I can take your full name.
Samir Agrawal.
Thank you, Dr. Agrawal. Your qualifications appear in the HAD report in Bundle 44, Volume 1, at page 184. And we'll just put that on the screen to start off. Page 184, please. But what I wanted to, we can obviously read them, and we can read your publication, what your particular service interests and your current posts involve. But really just to sort of set the scene. What's your current post?
So I'm a senior lecturer and honorary consultant at St Bartholomew's Hospital and Queen Mary University of London.
And what's your current role there? What does it currently involve?
So I'm a consultant hemato-oncologist. So I work in the hemato-oncology unit at St Bartholomew's Hospital, where we manage adults, people 18 years and older, with the full range of hematological malignancies, and we perform the full range of treatments available for those disorders, including so-called bone marrow transplantation.
Thank you. Now, within that, what's your principal specialism, the area you feel actually is the core of what you do?
I think it'd be fair to say but I have a reputation for being an expert, particularly in various forms of leukemia, in bone marrow transplantation, and specifically, particularly for all the purposes of this inquiry, infection management in people with these disorders.
Now, I wonder if you could expand on, as it consider it is important to this inquiry, what you mean by infection management in people with leukemias.
Okay, so I think it is very important to be clear that I'm a hematologist, I'm a hemato-oncologist. My academic qualifications are in the immunology of cancer and the immune response. I am not an infection disease specialist or a microbiologist. So my expertise in infection management is to do with the clinical application of how we manage protocols, how we try and prevent infection, how we investigate, and ultimately how we treat either proven or suspected infections. And within that, I've developed an expertise and an international reputation specifically in the management of invasive fungal disease, which is one of the issues for the inquiry. So in other words, airborne infections.
if we can just step back a bit, we heard some evidence yesterday on Tuesday from Professor Gibson, who heads the paediatric hemato-oncology unit at the Royal Hospital for Children in Glasgow. And she talked about, I think if I understood correctly, the idea that depending on a treatment and depending on the child, one might have an anticipation of how long a period of neutropenia will last, how long, what form it will take, how deep it will be. And one will then plan the treatment and the management of infection around that knowledge. Are we talking about the same sort of conceptual idea that you know about the patient, you know about the condition, you know about the treatment, and then you react or you plan for infections on that basis?
Absolutely. So, I mean, in broad terms, Professor Gibson, I completely agree with everything you've just told me. It's the two broad things happening here. One is, what is the underlying malignancy? And the second thing is, what are the treatments being proposed for that malignancy?
And how those impact on immunity and
absolutely
right.
Yes.
Now, we'll come back to invasive fungal disease, I'm sure, later on. You've obviously described your role in infection management, but what would be your working relationship with microbiologists in this context?
So, if we just go back a little bit, let's give some perspective. So, in 2005, I started, and this has now become the largest meeting in Europe, an annual meeting addressing questions of clinical mycology. So that's fungal infection. And that's something we've been doing now for 22 years. And that's really given me a certain expertise in that area. In terms of day-to-day working in the unit, we've developed what's called antimicrobial stewardship programs, and that's a key part of how we interact with our microbiology colleagues and infectious disease colleagues. And my input into that was I was the one who instigated that approach.
So what is antimicrobial stewardship?
So antimicrobial stewardship is really regarded as being a requirement for all NHS institutions, principally to manage antibiotic prescriptions with a view to trying to limit antimicrobial resistance, which is a major global health concern. What we do is, with microbiology colleagues, infectious disease colleagues, and pharmacy colleagues, and myself, we perform what's referred to as a AMS, antimicrobial stewardship round, looking at all of our inpatients with respect to their infection prophylaxis, infection treatment, if they're on treatment, and diagnostics.
So at a very high level, you're trying to not make the problem of antimicrobial resistance worse by the treatments you're applying to the patients.
Absolutely.
Right. Now, did you watch any of Dr. Drumwright's evidence yesterday?
I saw some of it.
I mean,
I was travelling in a train to the...
You were standing in a train?
No, I was travelling in a train to Edinburgh, so it was limited.
It would help me to understand when you came in, as it were.
In the afternoon.
So after 2 o'clock?
Yes.
Right, well, that's useful for me because there's points I'm going to come back to things. Now, before we do ask questions, I need to identify your reports and ask if you formally adopt them as part of your evidence. Now, I have in mind 6 documents.
Okay.
And I wonder if we can just identify them. There is this document we're in here, which is what we've called the HAD report, which starts on page 5 of this bundle. And that was produced by you and Professor Hawkey and Dr. Drumwright in July of last year.
That's correct. Yes.
And then we have a short note about your calculations for chapter 8, and that's in 44 volume 2.
Yes.
At page 107, yeah. And then we have what we've come known as the HAD response document, because you were asked by us to respond to various reports we got into your report. And that's the 19th of July, and that is bundle 44, volume 5 at page 20.
Just to confirm, this is a so-called first response. This has had one our response.
No, this isn't the questionnaires. I'm about to come to the questionnaires. This is the standalone document that sits alongside the second questionnaire.
Yes. Thank you. Yes.
And then you have an earlier report which you produced for NHS Greater Glasgow Inspector Ward 4C in 2021, which is the same volume at page 103. Now, can I just check with you? You've presumably seen this bundle.
Yes.
Did you apply any of these redactions?
No.
No. So the inquiry applied these redactions? Yes. And then we have the responses to 2 questionnaires we asked you. So it's the same, back to volume 2 of 44 at page 12. So quite soon after you and your colleagues the instructions were transferred to the inquiry, we sent you a questionnaire which asked some sort of initial questions.
Yes.
And you responded.
Yes.
Yes. And then a second questionnaire is in 44 volume 5 at page 4. Now, are you willing to adopt all these documents and responses as part of your evidence?
I am.
Thank you. Now, what I wanted to do is then to look at your letter of instruction, because that's in 44 volume 1, document 3 at page 234. And it's dated the 21st of November 2022. Now, it seems to be in exactly the same terms as Professor Hawkey's.
Yes, I believe so.
How was it you came to be instructed in this project? What was your first awareness of it?
If my recollection serves me well, I think Dr. Ash Rebello must have contacted me since we'd already been in contact with respect to the previous report.
Into 4C? Into 4C?
Yes.
Yes.
That's right. So with respect to ventilation and infections pertaining to ventilation. With the request that would I be willing to get involved in what was a broader investigation, in other words, the Scottish Hospital inquiry, in terms of infections not limited to paediatric and adult hemato-oncology, possibly on a wider scale, for which Professor Hawkey had been engaged, and would I be happy to do that with him?
So Professor Hawkey had already been involved before you?
Yes, I believe so, yes.
So what was the original nature of this investigation as put to you first?
Well, as it says, I think, in the letter of instruction, that certainly when we were discussing this with the CLOs, is it?
That's the name of the agency, yes.
To refer to the CLO, that we were told that the scope of the inquiry was potentially broadening. So that was one aspect of it. And they wanted to have an independent opinion on what were the actual infection rates occurring within the Queen Elizabeth University Hospital and Royal Hospital for Children in terms of the period of time since these institutions opened. With the background that there had been concerns around potentially patients acquiring infections because of failures in the environment of the hospital. So I think that's broadly how it was put to us.
So ultimately, your investigation into both bloodstream infections and aspergillus became focused on hematology oncology patients.
Yes.
But it seems from your initial conversation, the look was at the whole hospital.
Well, the impression certainly I had, I assume my Professor Hawkey had as well at that stage, was it wasn't necessarily restricted to the hemato-oncology population, but in terms of trying to address the question from a practical perspective, it was reasonable to look at those patients who potentially would be most affected by failures of the environment with respect to infection prevention.
And this is your idea that these patients will be the ones having intensive chemotherapy.
Yes.
And if I get the acronym right, HSCT.
That's correct, yes.
And that is what's known as bone marrow transplant.
Yes, colloquially, yes.
And so this, I think narrowing might be the right word. This is narrowing from the whole hospital to that group.
Yes.
Did that come from you or from those who instructed you?
if I'm frank, I actually can't remember which direction that came from. From my personal perspective, it was a sensible approach to make the task manageable. The task already seemed to be potentially a very challenging one because of the scale of what we might be dealing with. In terms of data, I mean, in terms of information.
Thank you. Then if we just step back to Professor Hawkey, had you dealt with Professor Hawkey before?
Not in any capacity I can recall, no. So neither professionally nor in any other capacity.
Right. And what I wanted to look at is in the letter. If we go to the second page. Well, firstly, go to the bottom of the first page. There's at the background, so 234, we start at the bottom of 234. There's a narrative description in this letter of instruction, which runs over the page and makes reference to various things that have happened in the hospital.
Yes.
And then the instructions at the bottom of the page and states that all of these infections have been subject to intensive investigations, both by NHS, GGC, and external bodies. What I wanted to understand is, I think it's the case that you haven't reviewed these other investigations, have you?
No.
Can you help us understand why?
Yes. So when we were discussing this, the question was put to us, in our opinion, how could we best answer the questions being put to us? And essentially, the question being put to us was, if there were failures in the water system at whatever level in the ventilation system, and that was leading to infection in patients were acquiring infections because of those failures, how would that manifest itself in terms of infection rates? Clinically, what would we expect to see? So
and do we actually see that on the top of page 236 in broad terms?
Possibly. Yes.
Yeah.
Yes.
Now,
and so to answer your question, so Professor Hawkey and myself discussed what was the best way to try and answer that question. We'd been presented with, as it says in the letter of instruction, the fact that a lot of information had already been considered looking at these issues, and what had not been done was there was no, if you want, baseline and a comparator to see what were the infection rates and were these within any expected limits or not. And that was very much how we focused our approach.
so you're looking for a comparator.
Yes.
Might it be fair to say that, in a sense, you're testing the hypothesis that if you have a comparator, or indeed a patient group that moves from somewhere to inside the hospitals, there will be a difference, or will there be a difference in the rates between either the comparator and the hospital or the place before the move? Is that effectively what you're doing?
Well, we felt there was an obvious comparator, and that was before the QEUH and the Children's Hospital were open. The same population of individuals were being managed at other sites. So looking at the infection rates at those sites would offer us some form of comparison as to what then occurred when that population of patients moved.
It has been suggested that the weakness of that approach is that the places where the patients, if we stay with the hemato-oncology patients, the hemato-oncology patients were located beforehand, were to some extent older buildings, some Victorian, and therefore a comparison between the hospital environment in an old building and a new building is not entirely fair.
I can understand the logic of those statements, and I accept that. I mean, we're also faced with the reality of what is a reasonable comparator? And how can we aim to get the best data to give us, one, a baseline of what's actually occurring, and does that represent data of concern or not? So I would put it to you that it was a reasonable comparator to take, not the only one, but I know in other reports that perhaps we'll discuss, other comparators were done by other experts who've given evidence to the inquiry. So there were other approaches to take.
Well, I mean, one of the options exists, which I suppose is for the adult hemato-oncology patients, would a suitable comparator have been your unit at Barts?
Potentially, yes. Yes.
Why didn't you look at that as an approach?
It wasn't, well, I mean, it was a question of deciding which approach to take within a time scale that wasn't entirely defined, plus resources. So the resources we were working with at the time were those of the CLO and the data available in the health board's system.
So you had access to, you could have asked for any information that Greater Glasgow and Clyde held, could you?
Well, I assume so, yes.
Yes. The other comparator point that is made, well, two points made. One is made, and it's made against Mr. Mukherjee's exercise, and also an exercise carried out by HPS briefly in October 19, is that the danger of comparators is that they will be too different. They'll either be too big or too small or too new or too old, or the population will change. And do you feel that by having simply, in a sense, one comparator for each patient group, the place they were before, that you run the risk that, I think the concept is confounding, that the other factors will come in which will muddy the water, literally, in the design of the study?
I think everything you've said there is valid, and it raises the challenge of having the most suitable comparator. I mean, another issue that is impossible to, unless statistically it can be done, but that's not a question for me, is to address chronology. Because if we're looking back in time, we're looking at a period of time where things were necessarily different and medical management evolves. But that's the nature of making comparison. I think we accept the limits of what we can do. So I don't disagree with you, but we're also making an attempt to have some sort of comparator in order to make sense of what we're looking at.
What was your state of awareness of what was being done by the health board to address what was seen by some, including some people in the health board, as inadequacies in the ventilation system of the building?
Well, that takes me back to the report that I'd prepared earlier in 2021 with respect to specific question around the ventilation system for the adult bone marrow transplant unit. And
so, sorry, you looked at 4C?
Yes.
It's not the adult bone marrow transplant unit?
Sorry.
Did you look at 4B?
I'd have to check at my report, sorry.
So, I mean, just check in here. When you say the adult bone marrow transplant unit at Queen Elizabeth, what ward is that located in now?
Again, I'd have to check, I'm afraid.
Well, I mean, is it the ward you were looking at when you wrote your report in 2021?
Without
well, let's look at the report.
I can't answer that.
Well, let's go and look at the report, which is 44, volume 5, document 3, page 103. So I don't particularly want to go into why the report was prepared over the page. We passed through your qualifications, perhaps. We've seen them before. Make sure I've got the right document in front of a copy, so I can take you straight to the right pages.
I think it probably is the right document.
I think this is the right document.
It is the right document. I'm just wanting to jump around it without taking a long time to walk through. And of course, I'm wasting time getting my copy in front of me. Maybe the place to go to is page 105, the next page, where you've done a summary. And you see at the start, Ward 4C.
4C.
So do you understand that to be the bone marrow treatment ward?
Without checking, I'm not sure.
Have you visited the Queen Elizabeth?
No, but it's not been part of our activity. Your
No.
Lordship.
So you've never been to the hospital?
Sorry, no, I've never been.
I suppose a question that would help me resolve this,
Yes.
actually, because I always feel when people can't quite remember facts,
Yes.
what you do is try and pull at a thread and see if it helps memory. If we go into your report, you discuss your unit at St Bartholomew's, and I think you do that. Let me just make sure I get the right page reference. I don't want to jump around too much. Well, can we go to page 116? So do you see at 5.5, you were discussing infections. We'll come back to this in substance, but the reason I'm going to it is to mention, do you see how you're discussing a comparison with the infections in the hemato-oncology unit at Barts?
Yes.
And you go on to the next page at 117 in a discussion about material risk of infection to make reference at F to the HSCT service at Greater Glasgow Health Board.
Yes.
Was it your understanding that Ward 4B carried out what is colloquially known as bone marrow transplant?
Do you mean 4B or 4C?
4C carried out bone marrow transplants.
I actually can't remember anymore.
Well, what I think I'll ask you to do is we've got a lot to do today.
Yes.
So when we come back after lunch, I wonder if you might see if you can, I know you brought your notes with you.
Yes.
I wonder if over lunch you could just check your notes, because I'd like to come back to this at 2 o'clock. But what I'll do is I'll go back to where I was and
just to clarify something.
Yeah.
So point F there, saying the HSCT service. I know HSCT is our abbreviation for hematopoietic stem cell transplant.
yes.
At St Bartholomew's Hospital, we do not have a separate transplant service.
Yes.
So when I refer to that, and as it's stated there, the JC accreditation, which verifies whether a unit is working at a suitable level or not, is effectively accreditation for the whole service.
Right. So
That's the point I think I was
I think what I'll do is I'll put something to you.
Could I just take a detail, because I'm not entirely clear about this. The JACIE accreditation is an international minimum requirement for transplant services.
It is a minimum requirement for, let's say, bone marrow transplantation.
But it is focused on transplant.
It is. However, Your Lordship, the JC process reviews the processes of the unit. And in an institution like ours, at St Bartholomew's Hospital, our processes are the same, whether it's a stem cell transplant or it's an individual receiving other forms of treatment. So they, in fact, cover our standard operating procedures, regardless of whether it's for transplant or non-transplant.
But other sites might have a different.
They may operate differently.
I wonder, actually, I think I might have found where you'll find your way out of this. If you go to page 125 of the HAD report, so it's 44, volume 1, this is in your Aspergillus chapter. And I don't want, no, volume 1 of 44. Page 125. So we'll come to this eventually, but if you look at the paragraph below the figure,
Yes.
the adult BMT service moved from the Beatson Institute to Ward 4B, Queen Elizabeth, on the 6th of June 2015, but then returned to the Beatson wards B8/9 on the 8th of June 2015. Adult BMT was permanently placed at Queen Elizabeth from the 30th of June 2018. the distribution of cases in adult BMT service in the split site years of 15 and 18 is 6 versus none. Well, that's about cases. We'll ignore the cases. Then what we do is we go back to the BSI chapter. In the same volume, page 69. So this is where you're about to discuss bloodstream infections in adult patients in chapter 7. See at the top of the page, for adult patients, data was examined both by consultant sector, BMT, North and South, and by months and years in which the consultant section was assigned to either Queen Elizabeth or other locations. And then it describes the allocation. So South and BMT were attributed to Queen Elizabeth the following way. The South sector became Queen Elizabeth in May 15 and remained part of Queen Elizabeth through 2023 when data provided stopped. BMT became part of Queen Elizabeth for a period of approximately 1.5 months across the months of June, July 15 and from June 2018 onwards. As bed days were only available, and then you describe the split. So what I want to put to you, but ask you to reflect on, is the inquiry understands that the adult BMT unit, when it's in the Queen Elizabeth, is in Ward 4B. And that's where what is colloquially known as bone marrow transplants take place. The South Sector Haematology Ward, when it's in the Queen Elizabeth, is generally in 4C, and at one point it pops into 4B when the others aren't there. And before that, it was in Ward 24 in the Southern General Hospital. Now, can I ask you just to check that over lunch?
Okay.
And I'll come back to that at 2 o'clock because it seems an important point. What I'd like to do is to return to our discussion of methodology.
And just flagging a point, at some point, I would be interested in knowing from Dr. Agrawal the detail of his unit in
absolutely.
BART.
We'll do that then,
I'll-
I think, Lord.
Yeah.
So what I'd like, we'll come back to that in terms of your other report, older report, and we'll do that all after lunch.
Okay.
So what I want to do is just go to the appendix to the letter of instruction, which is at page 237 of the same bundle, because both you and Dr. Professor Hawkey received the same appendix. And I want to have a discussion with you about the conceptual design of the whole study. Do you see how at 3 it states, if there was, quote, widespread contamination of the hospital's water system, and then there's a list of things that this might be down to, and there's a Roman numeral footnote. And do you see the document at the bottom?
Yes.
Have you read that document?
I don't think I have, no.
Right.
No.
And then series of questions are asked, and I suppose 5 is where Dr. Drumright comes in. So would it be fair to say the process described here is you are being, what is the process? What are you being asked to do before you get to the data? What are you comparing with what?
Well, the premise is there may be infection arising in patients in the hospital from the water system in some way and or failures in the ventilation system.
Right.
And from that, what would we expect to see and how can we try and answer that question?
So in order to do that exercise
Yes.
for the water, to what extent do you need to know what is the nature of the suggested failure in the water system?
Well, our approach was not to consider that. And the reason for that was we decided to focus on what were the infection rates that we could establish. Because what we were aware of concerns around apparent increased rates of infection. And so what Professor Hawkey and myself discussed was, well, how would we establish that? How could we demonstrate that that was the case or it wasn't the case? So that is how we approached trying to answer this question. And hence our desire to try and get as much data as was available from the Glasgow Health Board in terms of the infections that had been documented.
So just to ask the same question in terms of ventilation, in order to answer that sort of question around ventilation, do you need to know what the nature of the perceived flaw in the ventilation system is?
Well, I had some knowledge about that because of previous work already. But it was really the same approach. So the same approach to say, well, what did we observe? Not we, so what were the observed rates of infection? And then attempt to see, does that correspond to what may be expected, or was it an excidence?
So when you say what may be expected, did the CLO, other than by this footnote, which would tell you the answer, because we've read the document, did the CLO tell you that the Greater Glasgow and Clyde Health Board publicly expressed position is that by a point in 2019, or maybe a little later, but in that sort of territory, they had the water system under strong control, and that interventions such as putting filters on taps taps and showers in all high-risk areas had been completed in March, April 2018. Did they tell you that, other than by the reference in the document in your letter of instructions?
No, I'm fairly confident this is something we've become aware of more recently. It was not something that we were told at the time.
Well, shall we look at the document you didn't read? I wonder if we can go to
Really, just for my note, Dr. Agrawal, to understand your last answer, you only became aware recently of any information about remedial measures. Is that, have I picked you up correctly?
I think I need to just caveat that slightly, but the details, I mean, I think we were aware that there were many efforts going on to address perceived risk, but the details of those efforts we had not investigated. We didn't have the documents to look at.
When you talk about the details, you mean the nature of the measures?
Yes.
And the dates when they were applied?
The exact dates, no.
Thank you.
I think probably, yes, it's in bundle 18, document 11, page 819. The reason I want to put this to you is because I want to suggest something else that you could have done in terms of the study design. So if we look at these, this is 819. This is a report by Health Protection Scotland. Are you aware of who Health Protection Scotland are?
Yes.
Yeah, so they're not part of Greater Glasgow and Clyde Health Board.
Yes.
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 And they produce a summary and incident of findings of the water contamination incident and with recommendations, and it's December 18. And then if we go to page 821, we have an executive summary. And you see in the third paragraph, it explains that between the 29th of January and the 26th of September, 23 cases of listed infections. And then second sentence, as a result, further testing of the water supply was undertaken across both hospital sites. And it refers later in the decision to put point-of-use filters in wash hand basins in Ward 2A and other areas where patients were considered high risk. It talks about drain contamination. And there's a long list of interventions there. Now, what I want to suggest to you is that if you wanted to do a comparator between a comparator that would have been perhaps more interesting and less risky, would have been to compare before the interventions with after the interventions, because then it would be the same hospital, the same patients, but in the case of the water, with luck, the water isn't reaching the patients in the state it previously was. Yes. Would that have been a helpful thing to look at?
I think effectively we have looked at it.
But you don't know the date of the interventions, do you?
No, but in the analyses performed by Dr. Drumright, we, and she has analysed, have taken all the data available from the Glasgow Health Board. So,
well, no, let's go back to Bundle 44, Volume 1, page 237. This report was available to you when you were instructed and you didn't read it. So you had the report from HPS available to you in November 22, describing the intervention, and yet you didn't read it. And the difficulty that poses to me is a question that I'd like to think about, which is this inquiry has been given your report, and we have been encouraged to give weight to it. And the difficulty that I'm pondering is, in a normal concept with expert witnesses, you sort of expect an expert witness to have considered all the available material, to reach one conclusion, and then to defend is not quite the right word, deal with it in the context of other people's opinions and maybe small extra pieces of information. What you don't expect to happen is an expert to produce an opinion without taking account of information that was available to them at the time. And so what weight should we give to your conclusions when you didn't look at material that you were given at the time that would have told you what was done to address the widespread contamination of the water system that was found by Greater Glasgow's own employees?
the way I see this, I think that there's separate issues here. So one is contamination of the water system, failure of the ventilation requirements. The other is what were the impacts of those findings on patients? So we took an agnostic approach from that perspective, and hence the desire to look at data over time in order to make comparisons. I realize the point being made that comparisons with other institutions may be limited by the fact those institutions had different environments. But equally, the data we looked at does include all of the time periods and time points you're referring to. And hence we can look at infection rates in relation to those time points.
But you didn't in the original report?
Not in our original report, no, we didn't. But subsequent to comments made to our original report, then such analyses have been done.
Right.
Yes.
Well, let's move on. I'll come back to the...
Just again, my notes. We took an agnostic approach. What did you take an agnostic approach to? Was it whether or not there had been contamination or failure in the ventilation system? Or the second question, which was, what were the impacts?
We did not make assumptions about whether there had been or whether there was contamination, but we accepted that if there was, what might we expect to see? And also, we didn't make any assumptions of the impact of other measures that may or may not have been happening within the Glasgow institutions to try and address the problems they were seeing. Because what we wanted to do was try and establish what the incidence rates were. And from that point, then try and make some statements about what was the impact of those perceived or real failures on patients in terms of infection rates. So that was, when I say agnostic, I mean in that sense, Your Lordship.
But Dr. Agrawal, if you wanted to look at what was the impact of perceived failings in a system, do you not need to know when they stop? If they stop?
Well, I would suggest that we would see that in the data.
Well, I appreciate that, but in summary, your original report, you don't see it in the data. And then you do, to some extent, see it later. And so I'm wondering, is it helpful to the inquiry to attempt to look at what's the impact of a perceived failing without knowing its temporal or geographical extent?
Well, I think from the work that has been done, the answer to that is yes, because the analyses that I've seen, which on reanalysis of the figures and graphs, do show. Firstly, I would absolutely agree with you. Our initial impression that we couldn't see a signal of increased infection rates in bloodstream infections in the paediatric population was changed with further analyses performed by Dr. Drumright. I'm not aware the data changed. It was the nature of the analysis that changed.
Right.
The models used.
Well, I'll come back to that after that. I want to get on with some other stuff first. And so I think probably the most important thing to do in terms of basic housekeeping is just to make sure I've got the division of labour between you all so I can ask the right questions in the rest of your evidence, the right person. Now, the paper consists of an executive summary and 8 chapters. And Dr. Drumright described it, in essence, that chapters 1 to 6 were very little to do with her. Part of chapter 7.2 was her, and then subsequent work on Aspergillus after the report had been produced was her as well.
Yeah.
Would you agree with that in terms of Dr. Drumright's involvement?
Yes.
Yeah. Right. Now, for you, working backwards, is chapter 8 effectively your work?
It is.
Right. Well, we'll do that with you. Within the rest of the report, I have already been discussing with you conceptual design, and you're comfortable to deal with that. The design of the whole study, is that something you feel comfortable to talk about?
Yes.
Yes. One of the topics addressed within chapters 1 to 5, or 1 to 4 rather, is the idea that you need to know a normal rate in order to understand when there's been a change. Is that something I can discuss with you?
Yes.
Yeah. Then there's the topic of whether whole genome sequencing can be used to prove the absence of a connection. Should I address that to Professor Hawkey or to you?
I can make general comments, but I think Professor Hawkey, that is his area of expertise. He is the person who has written that section of the report. So I would have thought it.
Well, we'll do that briefly and see how we go.
Okay.
Then there's the topic which Dr. Drumright was keen to defer to the two of you, was whether there was an issue with antibiotic resistance. Is that something you can help us with?
Yes.
Right. Then chapter 6, ventilation, that will be something we can discuss with you.
Yes.
And did you write most of that?
I did.
Right. So we'll do that after lunch as well.
Okay.
And then within chapter 7.2, do you feel comfortable addressing interpretation questions around the BSI results?
Yes.
Right. Now, can I ask you this question? Who amongst the team, well, actually, I'll address it to you. What experience or expertise do you have in pediatric hemato-oncology?
Through my training as a haematologist, as a registrar in haematology, I worked at the paediatric unit at the Royal Marsden Hospital, St George's University Hospital, which provides the PICU facilities to the Royal Marsden Hospital, managing children with hematological malignancies. As an adult, as a consultant, I would not regard myself as an expert in the management of pediatric hematological disease. However, I do regard myself as knowledgeable about the infections that individuals acquire, as we discussed earlier, who have hematological malignancies and transplant and intensive chemotherapy. And the principles of those issues are the same, I would suggest, in adults and children.
In terms of the practicalities, when did you last treat a patient under the age of 16 with a hematology-oncology condition?
Oh, that would be as a registrar. So that would be many, many years ago.
When did you
In the
become?
1990s.
In the 1990s. And that would be when you last worked in the paediatric hemato-oncology unit.
Yes.
It's been suggested by the CNR expert panel in their rebuttal that none of the three of you have experience sufficient to be an expert witness in paediatric hemato-oncology. How do you respond to that suggestion?
Is that rebuttal suggesting that we should be experts in managing hematological malignancies, or is it suggesting we should be experts in managing infections that such individuals may get?
Well,
because I'm slightly unsure of what the suggestion is there.
It doesn't say that. And I suppose that the question of whether you are an expert is ultimately a question for the inquiry, not for Professor Stephen or anyone else. And so the way I reflected on it was this, and so I'll put this to you. We've heard evidence, which I don't think is challenged, that paediatric hemato-oncology patients are not little adults. Their size, the way they move around, what they do, how they behave, and how they can't be expected to maintain the same level of hand and line cleanliness as an adult, make them different. Would you accept that's something that might be true?
That is true.
Yeah.
But the implication of that is that they are at greater risk.
Well, that's what I wanted to come to.
Yes.
The same thing that might imply the same thing is that because they're smaller and they have more, and the diseases they suffer from last longer, are sort of more systemically harmful, that they're actually a lot more vulnerable than adult patients.
I'm not sure I could agree with that statement. I mean, in adult hemato-oncology today, we are dealing with an increasingly older population that we are now treating in a manner that we wouldn't have done 10, 15 years ago. But as the individuals get older, they have significantly increased risks associated with their management, particularly infection. So I think that balance of who is most vulnerable is not so easily defined.
But what should the inquiry do when faced with evidence from 2 or 3 Glasgow consultants, including Professor Gibson and Professor Stevens, who see the paediatric hemato-oncology patients as singly more vulnerable than their adult equivalents, partly because of their physiognomy, partly because of the diseases they suffer from, partly because, well, they're children and they play and they do all these things. So when they tell us that, and you say in your report, and we'll find that in the text, which is, if we go, I think, to this bundle, I'm pretty sure it's on page 61. You make a statement at the bottom of the text. This is a chapter in chapter 6. And I'm assuming that would this become evident as a reference to would a problem with the ventilation system in the heading?
Yes.
Would this become evident by way of an increased rate of infection in the patient population as a whole, or other particular vulnerable patient groups where this may be more evident? And then there's a discussion in here. And what I noticed is that you list in this section the sort of people who might be most vulnerable. On the bottom of the paragraph, the highest risk population, the group of patients with hematological other cancer undergoing chemotherapy and HCT, sorry. And then over the page, we move to chapter 7. But if we go to the executive summary on page 6, is it your suggestion that we would see any increase in infections in both the adults and the pediatric groups?
Yes.
And so the difficulty I'm putting to you is that if those people who are currently treating the patients in the hospital and Professor Stevens, who used to be head of the Bristol unit, are telling us that the children are more vulnerable, then the use of the word both in that construction might be problematic. And therefore it might be possible to see a signal in the children. Yes, this is a problem with glasses. In the children, but not the adults. And I want to put that to you, but I'm conscious that I'm putting that into the context where you're not a pediatric endocrinologist. So how am I supposed to deal with that problem?
Well, my answer would be I'm not the right person to definitively answer that. My experience in terms of clinical care is with adults, and the nature of the defects that render this population of individuals, be them adults or children, at high risk of infection are principally the same. I understand that the behaviours of individuals may be different, but that's to ignore the behaviour of adults and think that adults are not putting themselves at risk in other ways that, in fact, children are not exposed to.
Because
So
I appreciate that.
Come back to that balance thing. I'm not sure when my colleagues say what they say, how they would justify their own statements. I accept there are differences in children and adults, absolutely. But I'm not sure you can be so definitive about the difference in risk of infection.
Well, the reason that I'm asking you the question is you've been definitive about saying we would see the signal in both. And I think it's fair to say that at the end of Dr. Drumwright's recalculations, to some extent, and that matter is a matter for debate, there is a signal in the pediatrics, but by no means is there anything similar in the adults.
Yes.
So
Agree.
if that is the case, then this both word becomes quite important. Are you telling us that we should expect to see, if there is a widespread contamination of the water system, we should expect to see the signal in both? And therefore the fact that we only see it in one means we can exclude that. Is that what you're saying?
I would absolutely expect to see a signal in children and adults in these circumstances.
And you're comfortable that you have the expertise necessary to give that opinion?
Well, I'm certainly comfortable. I would expect to see it in adults, yes.
Right. Now, if we will return to the adults and the placement and their exposure to these water and ventilation systems after lunch. But what I want to do now is to move on to the concept of the normal level of risk, because we've had a lot of evidence and opinion about using the word normal and unusual. I'm trying to work out what they mean in different contexts. So I wonder we can go to the executive summary. We're on it already, and it's paragraph 5, and it describes what is an outbreak in the summary. I'm assuming you stand by the words in the executive summary.
Yes.
Yeah. And the paragraph before is to assess if there is an increased level of risk of infection, a normal level of risk must be established. What do you mean by a normal level of risk?
We are all at risk of infection, and this patient population is at great risk of infection. There is an inherent, it's not just risk, but there's inevitability that given the treatments, given the immune suppression, given the damage that occurs to individuals based on the treatments they get, intravenous lines for access, that infections will occur. So normal implies what would be expected in those circumstances, and hence to talk about increase above what may occur because of the circumstances of the treatment of the individual and their underlying disease. So I regard normal as being what is in a sense inevitable, and an outbreak then, as follows in section 5 there, is something that implies something is happening that would not be expected.
Because one of the things confusing me is that I wondered if normal has this concept of normal level risk has different meanings at different scales. And what I mean by that is, I take it from what you're saying that if you think about the general risk of infections associated with lines, are you saying there would be effectively a certain inevitability there will be some? Is that effectively your position for line infections? Line
infections and other bloodstream infections, yes.
So in general terms, if you take a collective group, there will be a normal, there's inevitability about it to some degree. You can push it down, but eventually you can't push it any further.
Yes.
Right. But if you take an individual organism, what I want to look at is Mycobacterium cheloni. The reason it comes up is because it's quite an interesting scenario in the hospital, which I'll just mention to you. So there's a case 2018 in the children's unit, and then there's a case in 2019. And it's only in the inquiry that we realize there's a case in the system in 2016 as well, but no one at the time notices. And that all the evidence of those involved in that treatment, and indeed the inquiry experts, is that there isn't really a normal rate for Mycobacterium cheloni. It is something that should not happen. Would you accept that as for an individual organism? You can drop another one into that definition if you feel it's not an organism you know well.
I'm slightly unsure about when you say, Mr. McIntosh, it shouldn't happen. I mean, things do happen.
Well, I appreciate that. That's what I'm trying to explore. So if we sort of make it very vague to make it the concept, there's been lots of examples of members of the infection control team and the clinicians in the unit saying, we came across unusual infections.
Right.
And the way they mean that is that someone mentions patients has got infection A, and they go, goodness gracious me, I've never seen this before. I have to go and look it up.
Yeah.
That's basically the definition they're working on. And the same people, largely, then say, there can't be a normal rate for something that's so rare, I have to go and look it up.
Yes.
And that's obviously at the level of one organism. Would you disagree or challenge that particular conceptualization of normality in that context?
I don't challenge it, but the question I would ask is...
Or how helpful is it?
Yes.
So how would you make it helpful or use it or give it meaning? Would you have to increase the scale?
Well, I think that's extremely difficult. So in the context of, are we trying to establish that this very rare organism that doesn't normally cause bloodstream infections, even in the very vulnerable population, but we're finding it in an individual, yes, that would certainly cause me to think, well, why?
Yes.
What's happened? And then we go to, has it come from the water? Is it related to the air? Where has it come from? I can't really see a way of addressing that without having some techniques such as whole genome sequencing, but basically establishing that the clinical isolate is the same as can be found in the environment or wherever it's felt the organism.
So you would feel that the normal rate concept you're describing here in paragraph 4 isn't really relevant to this single organism?
No,
right.
It couldn't apply to that.
Okay. Let's go back to paragraph 5 and the idea of an outbreak. You've defined an outbreak is an increase beyond normally expected numbers of infections due to a specific bacterium. Relatedness of these infections in time and space provides circumstantial evidence for cross-infection. A strict definition is the occurrence of 2 or more cases of infection caused by genetically indistinguishable microorganisms. Is that how you manage your own patients? Would you wait for whole genome sequencing before deciding you have an outbreak of a particular bug?
May I give an example?
Please.
Okay, so 3 years ago, we had a case in our unit of a bloodstream infection with what's referred to as a multi-drug resistant organism, an MDRO. Extremely rare in our practice. We see very few of these organisms. And a few weeks later, we had a second case. A different patient, a different part of the ward. And so that rang alarm bells because it's not what we expect.
Yes, it's back to this, that definition of normal.
Exactly. Yeah. So we didn't then wait to say, well, let's do whole genome sequencing. And an investigation was started to try and establish what was happening. By the time we did get whole genome sequencing back, to our surprise, they were actually completely different. So it's the circumstantial nature of the evidence that needs to be verified by something that's more definitive. And so I agree, I wouldn't wait. But on the other hand, we would be making assumptions. And since then, to my knowledge, we've not seen another case. So these things happen. The assumption was the organism had come in with a patient who'd come into the hospital from another institution.
Well, that enables me to ask a generalized conceptual question about whole genome sequencing, and perhaps use your example, your experience as an example. I don't think there's anybody who disagrees with the conclusion that if two bloodstream samples are not closely related in terms of their whole genome sequencing, they are not identical. The question then, but if they are closely related, they come from the same source. That seems to be uncontroversial. You'd accept that if they had come back to you as within a few snips, I think, you would have gone, that's the same source.
Yes.
Right. Now, I don't know enough about this particular organism, but if we, for example, let's change it slightly and make it an enteric organism that can be in both the gut and the water, it can be colonized on patients. All these are possibilities. And you have two cases in a ward, as you say, in different parts of the ward. And initially you suspect they might be related by just applying basic epidemiological principles. However, you do eventually get whole genome sequencing back, and the two cases are some distance apart in terms of their genetic relationship. What definitive conclusion can you draw about whether there are or are not two different populations of that organism in your water supply?
Well, firstly, I'm not quite sure why I'm thinking it's coming from the water supply, unless we've grown them from the water supply.
No, you use water supply as I'll rephrase that, in your environment.
Oh, in our environment.
So let's imagine that you have this organism which you know lives in the environment. People have said, and it seems clear to me anyway, that if you had a single source that had a single population of microorganisms who were all genetically very closely related, and they get into two separate patients, you will find genetically closely related tests. I've understood that correctly.
Yes.
What happens if in that environmental source there are not one population, there's in fact two or three or four? How can the fact that two samples are not closely related exclude the possibility that, and I always get these phrases wrong, that the environmental population of that organism in your unit is polyclonal? Is that the right word we're looking for?
I think so.
Yes. How can it exclude the possibility that what you actually have is a polyclonal reservoir?
Yeah. So I really, on that point, have to defer to Professor Hawkey, as he is an expert in this area. And we're drifting into areas of microbiology that really are not my area of expertise. So I think I should not attempt to answer.
Fair enough. We'll do that with him. I think it's on Wednesday of next week. Another topic that's come up of a similar sort of nature in that it deals with a conceptual possibility that you want to consider when understanding this data, and that is the concept of antibiotic resistance and how. Now you need to tell me whether I'm asking the right question here. Am I right to think that this topic is effectively this: the extent to which the use of certain antibiotics in a unit will influence the population of organisms in that unit such that you get more than a normal amount of them? Is that the topic we're looking at?
Yes.
Right.
Broadly speaking, I think
Broadly
you've got
speaking.
it right, yes.
So at least I'm asking about the right topic. So
Sorry, can I just clarify my thinking? The use of antibiotics in a unit
Yes.
will, the policy, the practice will influence the population of microorganisms. Now, did you say in the unit?
I meant that in
or
the broadest
patient?
sense, both in the environment, the patients, anywhere.
Right, okay.
So I think
So it's not simply the population, sorry, it's not simply within the patient.
I didn't want to push it in one direction. I want to keep it very vague to check my understanding. So in a sense, there's a population, we'll not worry about where it is. It is influenced by the use of antibiotics. That's the theory that we're investigating effectively.
it's more than a theory. I mean, it's absolutely definitive that the antibiotics used within a hemato-oncology unit have a profound influence on the microbiological environment of that service.
And indeed, that's why there's considerable policies in these units about the use of antibiotics and what antibiotics they should use and when.
Absolutely. It's not just because of that, but I mean, the policies around antibiotic use are primarily derived to ensure appropriate treatment of a condition known as febrile neutropenia.
Right.
So that's in general what they're principally addressing. And within those policies, there's huge variation actually in what is recommended at any given site. And that should be driven by the microbiological data that exists for that specific unit. So you cannot take policy at one unit and apply it to another unit. It has to be tailored for a given site for the reasons we've just talked about, because the microbiological environment in any given institution may be very different from another.
So can you, in a sense, summarize the position taken by you and Professor Hawkey on this topic as it applies to the data for the BSI? So what did you think might be happening and why?
I have to answer this in two ways.
Yes.
One way is to leave Professor Hawkey to address the specific question which he has raised and really written in great detail about in our report, relating to the impact of the use of a drug known as Meropenem on increasing rates specifically of potentially of Steinomonas trophus infections, Steinomonas trophus multifilia infections.
Yes.
And so that's a very specific issue. In broader terms, for me, it's very clear that the antibiotic policies, not specific to the practice in the Glasgow hospitals, but something that's very widespread in hemato-oncology units throughout the United Kingdom, is the use of an awful lot of antibiotics in terms of trying to prevent infection. So in other words, prophylaxis, and I believe the units in Glasgow were using a drug called ciprofloxacin.
So why do you believe that? How did you find that out?
It's in the bundles. I forget, I'd have to look at my
But
notes.
did you know that when you wrote the report?
I knew from work I had done previously of febrile neutropenia policies in the adult service
In Glasgow.
in Glasgow.
You don't refer to this in your report, Dr. Agrawal. Why do you not refer to this in the original report if you knew it at the time?
It wasn't. Should I have referred to it? I'm
Well,
trying to explain to you.
what's worrying me, and I'll
Yes.
sort of jump to the
Yes,
point,
yes.
is this, is that I get that Professor Hawkey is looking at Meropenem,
Yes.
and we'll deal with chapter 4
Yeah.
with him
Yes.
on Wednesday. But a critique that can be made of him is that he hasn't considered various pieces of information which don't appear to have been made available to him. I mean, it doesn't say he couldn't have asked, but they don't appear to have been made available to him. And the Meropenem issue arose in this inquiry probably most prominently when Professor Leonard gave evidence last year. And he looked at a paper produced by Ms. Harvey-Wood and Dr. Peters and one of the pharmacists, Dr. Gourley, I think, in October 2018. And he looked at a chart and thought, well, maybe there's something going on here. So he gave evidence about that. Various people responded. And we now have seen, we've checked this morning, that in the unit in 2018, they gave consideration to whether there was a problem of antibody-resistant Meropenem, and for reasons I'll put to Professor Hawkey on Wednesday, they concluded that there wasn't. Now, I suppose the question for him on Wednesday is, how can you give an opinion on what might have happened without knowing what actually happened? And so in this case of this particular antibiotic, what knowledge do you have about what its use was and where does it come from?
So I'm not sure I understood the question.
So you've mentioned the new antibiotic and how it was used.
Well,
Oh, this is in the context of. So what I'm trying to.
well,
Sorry.
can I
Yes.
just
sorry.
see if I'm following?
Yes, sure.
Um,
Of course.
you were asked a question by Mr. McIntosh about, and it appeared to me that you were making clear that you were answering it at two levels.
Yes.
First of all, you mentioned Meropenem, and I took it that you were at that point saying, well, that's really a matter for Professor Hawkey. But you wanted to make a broader point,
Yes.
and you used the example, again, if I was following you, of the use of ciprofloxacin as a prophylactic.
Yes.
Now, I don't want to discourage you from answering Mr. McIntosh's questions, but if you were making a broader point, which effectively we have cut off,
Yes.
I would wish you to have the opportunity to make
Thank
your
you.
broader point.
So what's the point you're making about
I just hope
ciprofloxacin?
I'm following where we are.
What's the point you're making about ciprofloxacin?
No, you are. Thank you. The point I'm trying to make is, in order to understand the issues that, as far as I see them, as from my perspective of what's happened in terms of infection, be it contaminated water, be it a failure of ventilation system, notwithstanding any of that, there's a lack of clinical perspective, as far as I can tell, from the information that I've seen. And that clinical perspective is the actual management of patients. It may be the inquiries that addressed all of this. I'm not aware of that. And a huge impact comes from the use of antibiotics in general. It's not just Meropenem. It's how antibiotics are used, it's when they're prescribed, it's how they're changed, and it's the management of patients in terms of effectively fever-driven antibiotic use, which is how we practice clinically. And if that is not looked at, if that's not taken into account, then it's impossible to make any assessment of what that might be doing to the microbiological environment of the unit. And I I emphasize that because we have spent a lot of time in the work we do at St. Bartholomew's Hospital to try and address those issues. And what we've found is that we were talking about antimicrobial resistance a second ago. It is possible to reduce antimicrobial resistance by addressing these issues. Simply put, if you can use less antibiotics, you can change the the microbial environment of the hospital or your unit. And that changes what happens in the patients and the infections they get.
Yeah, I appreciate that, and I don't think anyone's contradicting that. I don't think anyone said otherwise. The problem I am facing as counsel inquiry is how to deal with this evidentially. So, Meropenem made its arrival in our consciousness in the evidence of Professor Leonard. To be fair, we should probably have seen it in the CNR overview report because it is discussed there. We had evidence about it last year, and there's bits and pieces coming out over the next few weeks, and Professor Hawkey will be very interesting about that topic. The problem I'm having, and the reason why I slightly jumped down your throat there, for which I apologise, is if we think about ciprofloxacin, if I pronounce it correctly, it's not mentioned as a possibility in your HAD report. It's not mentioned in your rebuttal document. It's not mentioned anywhere. All I've done is a keyword search in the two bundles, so I may be wrong, and now someone will correct me over lunchtime. But if that's the case, how do I deal with that? Because is it your position that we should be looking out to see whether there was a excess use of ciprofloxacin, and therefore there were, how did the ciprofloxacin resistant, is that would be the right thing, resistant organisms behave, or what would we see in the signal if this was a problem?
I don't think I'm actually saying that. I mean, I think that the points you make are all relevant, but what I am saying are things that are in our document is that an aspect of what's going on, is it the water, is it ventilation, is it line care, is also the clinical behaviour. And that's not just the clinical behaviour of teams, it's also the clinical behaviour of policies.
But that's not controversial.
Yeah.
My question is this, is that why do you think that's not already been considered?
Because I'm not aware of that information. I did say earlier that this may be something the inquiry's already addressed.
But the reason I raise this
I'm
is
not
because
aware of that.
the reason I'm raising it and I'm pushing back on you is that your report raises issues, and we have spent some time attempting to understand those issues, put them to the case notes review authors, put them to our own experts, the core participants, which include the Health Board, the National Services Agency, two groups of families, and a group of doctors, have proposed questions to you, and we've had a sort of exchange about this. And to an extent, I'm therefore ready to have a conversation with Professor Hawkey about Meropenem. I mean, whether I'll do it any well is an entirely debatable point, but we've done some work. But I'm not sure it helps to float possibilities other than just to say, have you checked for this? When you actually don't know what happened at the time, because you haven't read any of the contemporary investigations other than the case notes review. So how are you helping us by bringing this in at this point? It's slightly a grumpy comment from me, but do you see my concern that I'm trying to, now I'm going to have to investigate this as an issue, which wasn't previously on my radar. You could have mentioned it in the report.
I accept that. I mean, the simple answer to that is the report does mention the importance of, when looking at preventing infection, that it's a very, and I know the inquiry's heard a lot about the infection prevention, it's a very broad area, including clinical management, clinical behaviour. It's not just infection control policies, it's not just making sure the water's clean and the air is being handled as it should.
Right.
I think that's the point I'm trying to
Okay.
make.
Well, what I'd like to do is to put a document to you which has confused me, and I might get your help. So it's in 44, volume 1. It's document 6 and 7. I think we'll go to 7 first. That's page 248. Now, this appears to be a paper which we acquired in a particular way, and I'll tell you how we acquired it, but it bears to be written by Sean McBride Stewart, dated from the end of January of last year. It's entitled Public Inquiry Analysis of Antimicrobial Prescribing. We didn't instruct it. It appeared in the document, the data that was supplied to us by the Central Legal Office on behalf of GGC when you transferred, as it were, under our wing in March. And colloquially, we referred to this whole thing as the data dump. And it contains a lot of spreadsheets and for example, all your imaging when you did the Aspergillus project, all in there.
Oh, I see. Okay.
But this is sitting in there along with document 6, which is at page 246, which is an email. We'll take that off the screen. Now, the point is that that document isn't mentioned in the HAD report. We've not been given it by the Central Legal. Had you seen it?
No.
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 Okay, well, that makes it much easier. We can just put it to one side.
I've not seen that.
So what I want to just check, and I think you've already answered this question, which is, whilst you are raising these possibilities from your perspective, you're not raising them because you have gone and looked at what actually happened, other than to say, when you look at this data, remember antimicrobial resistance as a factor in it and consider it. Is that effectively your position?
Yes, just one very slight
Please.
caveat. It's not antimicrobial resistance, it's antimicrobial use.
Thank you.
Resistance may follow, but
It's the use policies.
Yes.
Right. It's the cause and effect.
Yes.
Okay. What I'm proposing to do now is to look at what might try as water, the water chapter, but not so much what's in the water chapter, because Professor Hawkey wrote that, but more the bloodstream infection works in chapter 7 and what we were testing. And in fact, I can't do that because I need to let you think about Ward 4C in order to do that. I think it's tied up in that issue. So we'll pass over that for the moment. And what we'll do is we'll talk about clusters. So if we go to the HAD report, volume 44, volume 1, which is section 7.2.2, which I think it starts on page 67. There's a discussion of the clustering exercise and the logic behind it. And then if you go on to the next page, page 68 in table 3, there is the criteria listed. And I'm showing you that just to sort of aid memoir. What I wanted, did you have any involvement in this clustering exercise?
No.
No. Well, that makes life a lot simpler.
Yes, no.
So that would be Professor Hawkey I talked about that.
This would be Professor Hawkey and Dr. Drummer.
Yes, her position is that she did the work, the maths on this, but the idea is Professor Hawkey, and her second attempt is all her, and I've discussed that with her.
Yeah.
Right. What I want to just do is to deal with the broad brush of the criticism of the whole of the CNR from your perspective. And so if we go to the introduction to the report, which starts on page 16, and I'm assuming you've read this and you agree with the contents.
Yes.
Yes. So if we can go to the end. Well, let's go to bottom page 16. You say a comparative exercise is essential. As before it can be said there is an increased, i.e. abnormal risk of infection, it must be first understood what a normal level of risk is. If, and over the page please, an increase of infection rates is observed, this doesn't necessarily mean that it's attributable to the built environment, as the causes of infection are multifactorial. Further risk investigation would be required to establish if the built environment was linked to any detected infections. What would be the nature of that further investigation?
Sorry, excuse me.
course. So that's the second sentence of second line of page 17. Further investigation would be required to establish the built environment was linked to any detected infections. What would be the nature of such an investigation?
Well, if the built environment was suspected, then that would be.
It seems to flow on from it if there was an increase in infection rates is observed. You see the top of this page?
Yes, yes. So that would be looking at all the factors that we've been discussing. So, is there any evidence of increased infection in water?
In the water sample sort of thing?
Yeah, in water sampling,
Right.
yes, of course. Also need to look at line care. In fact, I would say the whole range of things we've talked about.
So if there was, and I recognise it's a hypothetical at this point, if there was an increase beyond what is defined as normal rate is observed in the data, is your position that you would then require to have further investigations?
In terms of trying to attribute what's the cause of the increase.
And
yes.
is this where we get into the conversation that I hope you overheard with Dr. Drumright, about we look at scenarios and counterfactuals and we consider them all?
Yes.
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 And would you broadly ascribe to her approach that you got 5 or 6 different things to consider and we discussed what they
I
might
would
be?
suggest it's a reality, yes.
Yes,
I mean,
right,
it's,
okay. And then, however, if there is no increase in infection rates, then it can be included there is no increased level of risk from the built environment or other potential factors. And then the final paragraph.
I actually don't. Can I just? Oh, sorry.
Yes, please do.
With apologies. Does that actually follow?
I was just. Thank you, Wiltshire. I was just about to comment on that myself,
Okay,
but
well,
I'm not sure.
Please
Having
comment.
just heard it read back to me, that I would actually agree with that last bit. So it may be that there's no detectable increase in infection rates. That would not mean the built environment was not putting people at increased risk.
Yes,
So,
because one of the problems with, I mean, I recognise I'm about to talk about water, and it's not your thing. But are you familiar with the idea that water systems are managed in a way that focuses on risk, and you manage the risk by a process of managing the water through testing and controls and policies?
Absolutely, yes.
Yeah.
Yes.
And in your hospital, in your unit, do you manage the ventilation system in a similar way? You focus on risk rather than, yes.
Yes.
So would you, for example, have your ventilation system validated every so often by engineers?
Yeah, absolutely. Yes. The pressure gradients, etc., changes.
Since you've been at Barts, has Barts had any new ventilation systems fitted to new bits of the ward or retrofits or anything like that?
Absolutely, yes, we have.
Would you countenance opening a ward without validating the ventilation system first?
No.
Why?
Because you would like to know that the new hospital is working to the level that's expected from the specifications. And the reason for that, of course, is because we believe that's helping protect patients from harm.
And so how does that desire to have a validation exercise connect to the idea that, to the risk that the patients are exposed to? I mean, can I go as far as saying that an unvalidated ventilation system creates a risk, or is that linking two concepts that shouldn't be linked?
I think the dilemma here for me is that we have a new hospital, a ventilation system that's been commissioned, been designed, and it should meet its design specifications. If there was a question of, well, can we put patients in this space, then without validating it, that would seem demonstrably unsafe.
Right.
However, you would need to know something about the performance of the ventilation system, but that would not necessarily mean you were putting patients at harm. But
yes, because you've used 3 words that I think, even at 6 minutes to 1, I should probably explore with you. So you've used the word risk, you've used the word unsafe, and putting patients at harm, which I recognise is not a word, but it's a concept. How do you see those three concepts relating to each other?
All three are theoretical, because as has been discussed at some length within our reports, our various reports, there is firstly, there's very little evidence that the ventilation systems currently used, so the specification in SHTM 0301, the Scottish,
which is
version,
very similar to HTM 0301.
Yeah, absolutely. I think they're virtually identical. The English version is, there's virtually no evidence this has any clinical impact.
Because there were some studies done 30 years ago.
Yes, and in fact, clinical practice has moved on so far that the same patients we thought needed that sort of protection before, in some cases are being managed outside of the hospital entirely or partially. So the concept of the ventilation it sounds perfectly reasonable, but the data doesn't support that it actually makes a difference. And hence perhaps why so many guidelines do not specify that these ventilation systems are essential for managing patients.
So how does that connect to what I think you just said, that putting patients into a unit that have been unvalidated would be unsafe?
Well, I guess from what it doesn't feel comfortable as a clinician not knowing that the hospital or the ward we're about to use has not had some checks done on it. You would want to know its cleanliness levels. You would want to know that the air handling unit is filtering to the level it should be filtering. Because one of the problems with these systems is not just are they performing to specification, but if there's a problem, are they actually leading to infection, for example?
Because they might be blowing the wrong way.
Exactly, for example, yes. So that's why I say it'd be unsafe to attempt to open a new ventilation system unvalidated. But then when you step back from that, well, why would you do that? That doesn't make any sense. But when you have your fully validated ventilation system and it's working, perhaps this is a more constructive way of looking at it, does that mean the individual is not going to get infection from airborne pathogens? No, it doesn't.
So one of the...
Well, maybe we want to explore this further after lunch, but
there's a couple of bits I just want to pick up before we... You talked about harm as well. It's the third concept. I think we need to unpick what you just said, and I need to think about it quietly over a cup of tea. But in terms of harm, if it's your position that there's no research base for the idea that a non-compliant ventilation system causes infections, so I think it's what you just said. How is it causing?
right. When you,
I think I need to think about this more.
I mean, do you mean causes infection or reduces the available protection against infection?
Yes, let's not do that before lunch. Let's just do one final thought. I'm going to give you a thought, and I'll come back to after lunch. So we had evidence in the Edinburgh part of this inquiry from a Professor Humphreys. And he was dealing with this quandary of the lack of research information. In addition to observing you can't actually do this research, it probably wouldn't be ethical. I think he used an analogy about an old car, the sort of cars that we had in the 70s or 80s, in that as cars acquire safety features, or indeed you take them away, there isn't an obvious point when they become terribly dangerous. But if you take safety features off, you must increase the risk. Now, I always worry I misquote Professor Humphreys because that's a terrible summary. But to what extent are we dealing with sort of an issue like that, which once you've got a process where you now have modern cars with anti-lock brakes and seatbelts and all these things, and airbags, taking them away feels dangerous. Now, I recognize there is an evidential basis for all those features, but how would you react to the idea that having a unit that doesn't have the features it could have had is either suboptimal or gives rise to risk or is unsafe? Now, where would you stand on those three words being applied to that scenario? Not building a unit with the standard fit out.
Well, I think I come back to what I was trying to say earlier.
Yeah.
I obviously didn't manage it very well. So there is a regulatory, is that even the right word? There is exactly the sense that you said earlier that it feels like you're going backwards.
Mm-hmm.
It feels like you're going in the wrong direction. And if you're going in the wrong direction, then you must be potentially putting patients at risk of what you were trying to prevent them from being at risk of. However, for all the reasons listed in the report, that approach fails even when you have a fully compliant system based on our current regulations. And it fails for many different reasons. So your car with all its gizmos still can have an accident. You're not going to eliminate risk. And the nature of the risk means that, and also the nature of the ventilation systems we have, means that you are not achieving what you think you're achieving. I think it may have been alluded to yesterday by Dr. Drumright, I'm not sure, that even what we think we know about ventilation systems actually is not supported. That there's some, we know very limited amounts of are they performing even to the levels that we think they are with the specifications required. And hence, clinical practice is actually sort of moving on from the need for that. But it's still there. So we all have, I think all bone marrow transplant units in the UK performing allogeneic stem cell transplants. So just a little caveat that there are different forms of transplant which absolutely do not need that environment. But standard practice still is in the UK that those sort of transplants in general are performed in a compliant unit, despite the fact the evidence isn't there that it prevents infection.
I think that's probably a good place to break, unless something occurs, my lord, at this precise point.
Can I just let me just take the opportunity of making a general observation for your comment. Now, I think you agree with me that the sentence we looked at, beginning with however, actually does not follow. In other words, that simply because there is no increase in infection does not mean there's an absence of increase in risk.
Yes.
Would it be fair to say that if one looks at your report, the approach is to look not strictly speaking at risk, but what I'm going to call eventuation of risk. In other words, the occurrence of the event which one is trying to avoid?
I think that's exactly what our report is looking at, yes.
Right.
Yes.
So even if we find the word risk, we've got to understand that the approach of the report is to say, well, has there been an outcome which is supposed to be avoided?
Yes.
Yeah. Right. Well, I suspect we may come back to some of the things we've touched on this morning at 2:00.
Thank you.
I hope you have the opportunity for lunch,
Thank you.
Dr. Agrawal. But